of the gastroenterology registrars at Concourse Hospital. And I'm going to talk about nutritional cases today, going with the theme of today.
Just let me know.
So without further ado, I'm going to move about a 56-year-old gentleman who was diagnosed with Crohn's when he was 24 years old, and since then he was on different types of medical treatments and regimes. Unfortunately, he had a lot of surgical interventions. I'm going to mention some of them, or most of them. He had subtotal colectomy when he was 35, then had a further colonic resection when he was 42, and he had proctectomy and adhesionolysis when he was 50. And after that, actually, when he was 43, he presented with abdominal pain and vomiting, and there were features of small bowel obstruction. This actually was confirmed by CT showing thickening of the small bowel in the ileum and the duodenum, which is caused by flare of the Crohn's. Patient failed to respond to medical therapy during that admission, and he had ended up with interventions, having a surgery during that time with some of the small bowel being removed, and he had further multiple interventions and admissions, ending up to enterocutaneous fistula. So basically, the patient presented later to us with high output fistula, have parenteral nutrition already started by the surgical team for a couple of months, and he was jaundiced. And they thought it is due to parenteral nutrition at that time, and which can be justified sometimes. He had features of weight loss, and he had electrolyte imbalance. Really thinking about this patient, he has features of intestinal failure. So thinking about this patient at this point, I want you to think what kind of intestinal failure he has. Type 1 or type 2 or type 3. If your answer is type 2, you are correct. Basically, this patient had type 2 unstable intestinal, type 2 unstable intestinal failure. Intestinal failure as a term means reduction of the gut function to below the minimum necessary to maintain the health and the growth of the person or the body. The prevalence of chronic intestinal failure, which are the ones who are dependent on TPN in the UK, are 10 20 to 21 per million. It's not very common, but it's still a significant cost and very possible. Classification in general for the intestinal failure, type 1, which is a very common one. It's easy to treat and actually normally it's actually self-limiting. The surgeons see it every day. It is after like short and small bowel surgeries, and maybe acute inflammation like resolving IBD affecting part of the bowel. Type 2, on the other hand, is more prolonged, and they have prolonged acute conditions like abdominal sepsis, wound issues, enterocutaneous fistulas. Type 3, they are the more metabolically and physiologically stable people. They normally have TPN for long term, either for many years or sometimes lifelong. So that actually takes me to the classification and causes of intestinal failure. It's found that short bowel syndrome with the different causes leads to 2/3 of the cases of intestinal failure. And the top two for these are Crohn's disease and the surgical intervention. Actually, looking at some of the data from Salford and St. Mark's, you can see the number of the surgical interventions are actually increasing, leading to the surgeries leading to short bowel syndrome being the most common cause of short bowel syndrome in these people. Other causes are mechanical obstruction, when there's no moving gut, basically intestinal fistula. Another cause of short bowel syndrome. Actually, this patient has, if you look at it, has two elements of as a cause why he has intestinal failure. Intestinal dysmotility is another causative physiology, and extensive small bowel mucosal disease. Like, for example, radiation arthritis or extensive inflammatory bowel disease affecting the mucosa. Normally, these people will have intestinal failure as well. So how to approach intestinal failure patients? So looking at Salford approach to these people, they adopt a SNAP, which is very easy, logical, and easy to understand and follow. Basically, they suggest allowing for the sepsis to resolve first before getting to get the nutrition to these people and restore the nutrition. And once the nutrition is replenished in these people, then we can consider surgical reconstruction and restore the anatomy, which is the A in SNAP. And the final point is SP, which is a management plan, which will be either going for surgery or staying on long-term nutrition or adopting certain type of feeding or regime. So SNAP in sense is S for sepsis, N for nutrition, A for anatomy, and P for plan. So this patient actually, if you look into our patient, actually had sepsis. I'll come into that. I just want to explain how sepsis can lead to intestinal failure. Basically, it can lead to that by multiple mechanisms and pathophysiologies. For example, they will have nutrient transport issues due to inflammation, motility problem of the gut, which is normally inflamed during that time. They have high catabolism and minimal or reduced glucose utilization. So that will lead to malnutrition and GI dysfunction, which is eventually leading to intestinal failure. Normally, this can be easily reversed, obviously, by treating the underlying cause. The problem with people with chronic abdominal sepsis, especially people who had multiple surgeries and maybe malnourished, they will have abnormal YBCs in more than 50% of the patients or cases, and they will be febrile more than 50% of the time. So it's required high index of suspicion, and that is by looking for failure to thrive and continuous weight loss, low albumin, and hepatic dysfunction. Indeed, this patient had deranged LFTs and high bilirubin, which caused the treating clinicians to think about treating sepsis, obviously, and that's need to be on the high list of suspicion. So for these people, normally you need to start work them up as looking for the common sources of infection like chest, urine, do all the standard swabs for them. But the common infection in these people, or common source of infection in these people, is the lines infection. So in addition to line cultures, they will need some chest and abdominal imaging. Line cultures represent up to almost 20% of the patients attended Salford at some point. And normally what they would adopt is not choose the line when the patient arrives, take all the cultures and wait for the culture results before using the line. And actually, they won't use the line until they treat the course of the antibiotics, which is about 10 to 14 days. Obviously, this is unless the patient have overt septic shock or have fungal infection or metastatic infection, then the line needs to be replaced immediately. And the reason why to try to salvage the line in these people is normally it's very difficult, and they will have multiple lines throughout their throughout their life if sometimes long-term TPN is needed or home TPN needed. So this patient actually was treated with antibiotics and he normalized and the bilirubin normalized, and now he is cleared from the sepsis point of view. So now moving to the other component of basically of SNAPs. So this is now we're moving to nutrition. This is the end. So before just talking more about the nutrition in this patient, I just want to talk about short bowel syndrome, which is defined by insufficient length of function in bowel, leading to inadequate absorption of nutrients and water, and hence unable to maintain growth and or function. Normal adults have a small intestine of 275 to 850 centimeters, and that's very long enough to get all the nutrients and electrolytes and water throughout and get the right balance. But in this patient in particular, for example, he had high stoma output. So shorter bowel can lead to a lot of physiological trouble. Like here, I just want to ask a question: what high output stoma means, and what how much is defined as high output? So a lot of guidelines suggest like 1.5 liter actually of output with signs of dehydration is enough to put the diagnosis, and some suggest 2 liters with or without dehydration to suggest the diagnosis. And these people will have electrolyte imbalance and have other symptoms. So just to ask a question really, what do you think about the shortest length of bowel, which is enough to cause small bowel syndrome, short bowel syndrome? Is it 100 or 150 centimeters, 200, 220, 250? I'll just allow a few seconds. Okay, actually, this is a trick question because the length of the bowel itself is not the only determinant of the whether these people have short bowel syndrome or not. Studies suggest 200 centimeters normally is enough to cause short bowel syndrome, and that basically you need to take into consideration other aspects like the function of the gut, keeping the fluids in balance, and allowing adequate nutrients into the body before making the diagnosis. So all these constellation of things need to be considered before making the diagnosis. So possible features of small bowel, short bowel syndrome are they will have normally obvious risk factors, for example, extensive small bowel resection, surgeries, Crohn's disease, colectomies, or extensive IBD involving the bowels. They will have features of weight loss, as in this patient. Actually, he was significantly losing weight despite having parenteral nutrition partially and having some oral input as well. Volume loss and peripheral edema are other features. In fact, this patient had postural drop, and he had features of dehydration when he presented. Actually, I'm going to talk about the management of that aspect shortly. Other features like fatigues, fractures, postprandial abdominal pain, all these suggestive of short bowel syndrome. And now, as I said, we will continue with the nutrition part after we stabilize the patient from sepsis point of view. The question here will be whether to adopt enteral nutrition or parental nutrition. So each have advantages and disadvantages, and we need to consider. So, for example, enteral nutrition, it is reduces the risk of infection, and most of the people, they promote gut flora growth. It's more physiological, you would understand, and has less cost, as a patient can use certain type of food without the need for parenteral nutrition. However, there are limitations to enteral nutrition in these people. For example, if people have intestinal obstruction or had a blind pouch or ending cavity, should be avoided. The blind pouch can lead to bacterial overgrowth and actually worsen sepsis. And these people, we may consider keeping them nil by mouth and consider other way of nutrition. Short bowel syndrome and high output fistulas were other causes. Basically, this was a situation. This patient, we continued to try to feed him orally. Even we tried to correct his electrolyte imbalance, which I'll come to later, but actually without benefit. Every time, actually, we tried to wean him off parenteral nutrition. Actually, he dropped his weight and he had a lot of electrolyte imbalances. So the patient was started or actually decided to continue parenteral nutrition to improve immunity, allow for the wound, surgical wound healing, and plan next steps of surgery. So I need just to talk about like high output fistula or intercutaneous fistula or short bowel syndrome. Basically, standard treatment for these people, it is targeting to replace the fluids and correct the electrolytes. That is by keeping them nil by mouth if they have very high output, restricting their hyposmolar fluid. So even like plain water in these people, they can make a lot of trouble. For example, in this patient, he was taking like 1/2 liter, 2 liters of water, thinking that is good for him. Indeed, actually, that will wash out all the salts and electrolytes in the small bowel, leading to a more salt loss. That's why we advise to restrict the hyposmolar and isotonic fluid sometimes, because that will increase the absorption of the salts. Some people even adopt no hyposmolar fluid at all for managing these people. The other thing you can consider is the oral rehydration solution, which is the St. Mark's fluids, which is we commonly use. And I want you to think about what is the component of the St. Mark's solution or emix. It's just if you have any knowledge of it. Basically, it contains 9 millimole of sodium, has no potassium at all, made up of 20 grams of glucose powder, 2.5 gram of sodium bicarb, and 3.5 gram of NaCl, sodium chloride. And these can be actually prepared by the patient at their own home and try to drink it freshly. They don't need to buy it actually if they need, unless really needed. And as I said, this is the standard now approach for high output fistula. It is slightly different from WHO or rehydration solution. I'm not sure. So the oral rehydration solution, the WHO oral rehydration solution, they have potassium of 20 millimole, and the reason why we adopt no potassium in these patients is because normally, and some of these people, they have renal failure or have dysfunction of their renal function, which can lead to problems if they have any potassium in their diet. The other measures to adopt are anti-motility agents. Loperamide is the recommended one. They can take it half an hour before every meal and before going to bed. And if that is not enough, codeine can be used. And here we are using the side effect of codeine and giving them constipation to reduce the motility. Other things to consider are the anti-secretory agents like PPIs. For example, we put this patient on omeprazole, 20 milligrams BD. That will reduce the amount of the secretion, as a secretion from the stomach, and eventually reducing the output of the stoma, and also reducing the acidity of the output, which will reduce the irritation to the skin. Some people adopt octreotide. Actually, there's not much evidence that this will benefit these people. So now we finish with sepsis. The patient now established on nutrition and he had the right electrolyte balance. And so he's now on parenteral nutrition. Now we need to move to the next stage of SNAPs, which is the anatomy. We need to define the anatomy and map the bowels in these people, basically, if they are suitable for surgery or even introducing some oral feeding in the future. So we need to define all the fistulas, any strictures, any disease segments. We tend to use water-soluble contrast over barium. It can use anything like GI meal or small intestinal enemas, fistulograms, proctograms, basically any output area in these people. Scoping also can be used to look into the stoma and measure the length of the remaining bowels. And imaging is another thing, like using CT chest, using CTs, for example, or MRI, trying to identify the length of the bowels. So this patient, which is our patient now, we realized that after mapping his bowel, he has one fistula connected to the small bowel, inferior cutaneous fistula. He has 100 centimeters of small bowel remaining, which is connected to 15 centimeters of large bowel. Now, it's time to determine the long-term plans. Is he suitable for anastomosis and decide on type of nutrition? Actually, I just wanted to speak about a type of bowel resections and their suitability for their risk as well for short bowel syndrome. So mid-small bowel resection, which is meaning losing jejunal resection with more than 10 centimeters of the ileum and colon preserved. Normally these have very good outcome and they won't need TPN in most of the cases. Unfortunately, this is uncommon type of resections, and most of the people, they will end up having more extensive resections, putting them into type 2 or type 3. The type 2, the jejunal colic anastomosis, where the ileum and ileocolic valve remove. And normally, if you preserve the ileum, like in type 1, the ileum adapts very well for nutrients and salt reabsorption. In contrast to jejunum, normally it continues to lose these nutritional nutrients if there's no ileum. And also, ileocolic valve can reduce the transit time, allowing more time actually for reabsorption. So jejunal colic have again, they have the chance to be weaned off TPN. More than 65 centimeters jejunum is enough to attempt weaning. Jejunostomy or high output fistula, these are people who have duodenostomy or end jejunostomy. They are normally will be dependent on TPN, and unless they have more than 150 centimeters and good functioning bowel, most of them will end up having sort of parenteral nutrition. So in this patient, actually going to mapping, this patient wasn't suitable or felt suitable for surgery, and we're going to talk about that because he has very short bowel, and every time he's weaned off the TPN, he was basically losing weight and having nutritional deficiencies. So now we move to the plan of the SNAP. Now patients physiologically optimized, infection eradicated, he doesn't have any inflammation in the system, his nutrition optimized, his abdomen absolutely soft and ready, and at that time surgical discussion is needed. And patients normally they will have psychological support and intestinal failure units. It takes about 6 months to sort out these people and get them from type 2 intestinal failure and move them to more stable condition at 6 month time. This patient was discussed with the surgeons and deemed that he is not suitable for surgery due to the amount of the short bowel remaining. And this patient, as I mentioned, now he's moved from type 2, now become type 3, intestinal failure, he's more metabolically stable and he's stable on HPN. Recommendation for further monitoring of those people who are on TPN. As I said, we stabilize the patient, now all the plan in place. We need to make sure they are doing well in the community. We need to look for signs of parenteral nutrition failure, for example, like impending or overt heart failure, liver failure, sorry, looking like regularly on liver function test and looking for signs of jaundice. And basically that is a sign of TPN or PN failure. If the patient has at least 2 thrombosis of the central line, that is another indication of parenteral nutrition failure. If they have a central line infection frequent, and that is actually explained by 1 fungal infection or 2 bacterial infection, that's another indication of PN failure. The last thing is that when a last indication of TPN failure is severe volume depletion, even despite the fact they are on TPN. So other options to be considered in these people, they can use growth hormone, for example, that is to increase the absorption of the bowel, but the evidence for that is weak and not strong. And the other thing is lengthening surgeries. So there are some surgical techniques to cut the non-viable bowels and reconnect them to preserve functional length. The last consideration for these people is intestinal transplant. It is indicated for those who had any indication of PN failure, as we mentioned, like loss of venous access, which is simply to be the most common cause of indication for intestinal transplant according to ESPN guidelines, European guidelines, and recurrent line infections. Ultra short bowel, so those people has to have less than 20 centimeters of the short bowel of the bowel. Normally they will require a referral for intestinal transplant. Consideration and low quality of life, especially in young people or patients, they will require referral for transplant, those who spend there most of the time between having feeds and going to the hospital. So overall, looking at what we covered today, basically we discussed what intestinal failure can be and how present and its types. We talked about managing type 2 made intestinal failure, which with this SNAP, which is treating sepsis, getting them nutritionally stabilized and replenish all the nutrients, and then identify the anatomy of the bowels, and then a plan whether they need surgery or they need then they need to continue TPN. And basically we covered some areas of continuous follow-up for these people. So these are the references which the most of things covered from. Salford approach to intestinal failure is actually an excellent lecture by Dr. Simon Love, which I would recommend. And thank you very much for listening to this lecture. I will leave it in Dr. Feng's hand to get your questions. Thank you.
Okay, so that's the end of the last lecture on intestinal failure. The main take-home message from that is 2 aspects. One is to give you a structure how to manage high output stomas. The second is to think about using the SNAP algorithm to manage intestinal failure patients. I think it's a particularly simple and easy system, and it has a good rationale. You have to treat the sepsis first, because unless you deal with that, the body's physiological system isn't ready to absorb and maintain nutrition. And then you focus on nutrition, figure out the anatomy, and by doing that, you can then make a definitive plan. So obviously you have a plan throughout the time you're treating the patient, but you need a definitive plan. So I guess I want you to start thinking about your most recent difficult nutrition cases, whether they've had a enterocutaneous fistula or they've been on long-term TPN in hospital. Any questions or any problems you had with those patients that you want to ask now? There are no silly questions, so I recommend that you get those questions asked now and answered now, because that gives you a better understanding in the long term how to treat them. So I guess one question is hands up if you have your unit's intestinal failure unit. No, I didn't think so. And the second question is, are you completely clear about who to refer to for intestinal failure and home TPN? No hands up for that either. Okay, that's a bit disturbing. It's always important to know who your intestinal failure unit is, because while it's not very common, referring from home TPN is important. And that you have to take that in the context of the COVID effects, since a lot of places won't have beds for you to transfer the patient inpatient for. For example, the last patient that I referred to St. George's for home TPN didn't physically go there for assessment. We had to get creative. We used a laptop to do a teleconference through Teams with the patient and the St. George's intestinal failure team. And then we managed to approve her TPN, and we discharged her directly from our local hospital, which is a first for us. And I would say you mustn't underestimate the amount of work and coordination that requires. But it is increasingly something I think you will see happening, is where in certain selected patients, you may do a lot of the home TPN assessments virtually with your intestinal failure unit, and then you might discharge them locally from your hospital. So these are things you might have to start looking for in the future. So that pretty much brings our introductions for today to a close. I hope you've learned a lot from today's sessions. Just to recap what we've done today, essentially what I was hoping you'd get is an idea about, number one, feeding disorders, intestinal failure, chronic intestinal dysmotility, and gastrostomy care. Please learn from the mistakes I've had, which is that you should understand nutritional physiology, think creatively about what you're doing. And with that, I probably would like to end this session. As I said, I will send you a link when we have the availability of the videos uploaded. But if you want to, I'll spend a few more minutes on this meeting, so that if you want to ask any last remaining questions, you're more than welcome to. I wish you all the best during these difficult times, and good luck with wherever you're working. And hopefully, there's light at the end of the tunnel, so hopefully things will settle over time. Goodbye.